Hello, everyone. My name is Chuza Moon. I am an associate professor at College of Nursing and University of Iowa. And as a member of Education Committee at the National Center for Gerontological Nursing Excellence, I'm very honored to have our September Fireside Chat. This is a free monthly series for distinguished educators in gerontology nursing to share their expertise in this field, sharing their insights on key concepts in nursing, research, and education. Each chat begins with a brief presentation followed by an informal discussion where you can engage directly with speakers. Dr. Wiese is a professor at Florida Atlantic University, where she serves as both educator and researcher. She specializes Alzheimer's disease prevention and early detection in rural populations, with a particular focus on health equity and community-based approaches. She is currently leading an NIA R01 study on the role of air quality and built environment in social isolation and cognitive function among rural, racially, ethnically diverse residents at risk for Alzheimer's disease. In the next 15 minutes, Dr. Wiese will speak about her research, and I will distribute a survey link in the chat. So please fill out those survey. It's only 3 questions after hearing about Dr. Wise's work. All right, Dr. Wiese, it's all for you.
All right, thank you. Well, tremendous thank you to Hartford Nursing and Dr. Moon and Dr. Wan Chan and all those that put the work into it to make this effort possible. So as you heard, I'll be talking about community initiatives to promote brain health. I want to give a shout out to my faith-based health educators and this presentation, which was helped by several of them, Ms. Eiffel, Ms. Lawson, Ms. Wollaston, and so forth. And I'll mention more about that at the end. We don't have any conflicts of interest. The objectives are to identify 3 strategies to build local coalitions between rural residents and community partners, and 3 novel approaches to primary, secondary, and tertiary prevention of Alzheimer's disease and related dementias. So if you don't know anything about rural communities, the team put this slide together for a talk they gave earlier in Florida this year, and I really liked it. It talks about some of the key qualities and components that often make up rural communities. Even though we might have limited infrastructure and economic opportunities, there's often a very close-knit social structure that results in strong community ties. And that had a great deal to do with the success of our initiatives. I do want to point out that rural residency doubled since 1980, and the greatest increases have been from minority groups. And because of age and other factors, they have an 80% risk of experiencing cognitive impairment in their lifetime, and they have 2.5 times the rate of potentially preventable ADRD-related hospitalizations as opposed to urban counterparts. And a lot of that has to do with the social determinants of health that you see here: less healthcare access, problems with built environment, and they just don't have that infrastructure we talked about, and other things. And so, you may wonder, what do I do? Where am I? I actually live here in Boca Raton. So on a good day, like a Sunday morning, it's an hour and 15-minute drive for me to get to this area, Belle Glade. We do research all around Lake Okeechobee. This is a picture of the lake. It looks like an ocean. It's the 2nd largest freshwater lake in the contiguous 50 United States. The first one being one of the Great Lakes. And the people there are largely farm working and faith-based. I want to go back to that for a moment. I do want to point out this little circle here. This is President Trump's home, Mar-a-Lago. And so we talk about the disparity, because if you take the road out from there to Belle Glade, which is the biggest town that we primarily work with, it's also the most poverty-stricken, poorest town in the state of Florida. So we have quite a disparity there. So we look at, those disparities in dementia risk factors. And I also want to point out that it's what HRSA calls a trifecta or triple threat to residents because of the shortages in, hospital and clinic facilities, professionals, and so forth. The other thing is digital access and digital literacy have been remarkably low. It came up during COVID because students in high schools that did not have computers then got them. But they basically experience all 14 modifiable risk factors of Alzheimer's disease. This is a picture of a sugarcane field. I'm going to come back to that later on. And if you don't know what the all 14 risk factors are at Livingston, if you just Google Alzheimer's risk factors Livingston, it'll bring you up to the latest article on that. So how did I get there? I'm a white girl from West Virginia. I'm working with 88% racially, ethnically diverse group. And I want to say that my master's was in rural health nursing. So in my heart, I always wanted to go back to rural health nursing. And that was Belglade in that area that I pointed out. That was the closest. It's an hour and 15-minute drive, as I said. But I really enjoy doing it, especially once I get out outside the city and start heading out, as you all probably have experienced if you drive to rural areas. But I realized in my program at Florida Atlantic University at the Christine England College of Nursing, everything that we do is grounded in caring science. And so in case you want to know what that is, you can go to the Nursology website by Dr. Peggy Chin, a noted scholar in our field. And one of the things that I felt really fit what I was trying to do was Sister Roach's 6 C's of Caring. And so you see them listed here. And so this is how I apply the 6 C's to the work that I do. And I put it in terms of how did I get started? So first, comportment, recognizing that I was the outsider, what could I do to serve the community? Working with housing facilities, I had to have confidence. I was going in cold turkey. I didn't know anybody. I just went out there and knocked on their door, their office, and said, I'm a nurse. I'm interested in improving rural health. And, I want to know if I could do some education and health screenings here. And they jumped at that. Another important thing is compassion. People there are always needing some kind of sustenance. So I would bring like chicken wings and fruit and cheese once a month as I did these. And I did that for 2 years. So fidelity is really something, to show, to get accepted. And about that time, people got wind what I was doing and said, Lisa, you want to really reach people, you need to work through the churches. And so we did that using Schoenberg's Faith Moves Mountains model. And this was actually a KO1, a Career Development Award I received. And this is the thing that I'm proudest of the most. This team of faith-based health educators, which I'll explain a little more in the next slide, that work has continued to this day since 2017 because of them, because of their commitment. And a lot of times they do it voluntarily. And I just feel that, to see that sustained has been really, for me, the best part of my life's work. And I wanted to point out that another theoretical framework that I use, and we teach our students this, our students are judged on these qualities, is Boykin and Schonfer's Nursing as Caring framework. And so you can see these concepts I've put here at the bottom of the slide really fit well when you're trying to do community engagement. So I urge you to check that out. So, what are some key suggestions that I have, or strategies, in addition to service and working with your community leaders and stakeholders, is strategizing to partner with national experts. So, and I will say none of this would have happened without strong mentorship, and that's a whole other talk. But since I was a student, I've had a very strong mentor and Dr. Christine Williams, who helped me identify something unique that I could become an expert in and then run with that. And from there, I attended trainings. I still do that. Almost all of us could identify a summer research institute that you've taken part in or you could take part in to start to know the experts, because they're the ones running those. So people who lead the Alzheimer's Association, lead the NIH Alzheimer's research, I often am in the same room with them, talking with them because of these trainings. So that's really important, is to find a way to get with these leaders. You can do it through committee work in national organizations as well. When you present at conferences and you're there at conferences, go talk to them, introduce yourself, ask to have a quick, 15-minute meeting with them. Back in the day, pre-COVID, it was have a cup of coffee, but now it's all Zoom, right? But whatever you do, you want to make sure that you're getting feedback on anything you're doing. And if you ever present, make sure you don't waste that. You turn that presentation into a paper. And most of all, and this is something that I heard from both Dr. Williams and my physician mentor, Dr. Galvin, is this action going to support becoming a nationally recognized expert in my field of interest? So, in academics and practice, we all get pulled in a lot of different directions. So, you have to learn to say, no, I can't do that. I'm not super good at that, but I did try to follow this rule just to make sure that I didn't diverge too much from what I was trying to do, which was to become that expert in rural health. And I mentioned the Faith Moves Mountains model. So I just wanted to share this a little bit because this has been vital to everything we do. As you can see, we've expanded to all these partners: the Diabetes Coalition, the American Heart Association, the housing authorities, a varied health network that could name half a dozen have worked with us, the Glades Area Ministerial Association, sororities and fraternities. So this is all about education and screening and referring. Our problem has been lack of trained providers for referrals, and I'll talk more about that in a moment. These are some of the initiatives that the residents came up with: community cooking workshops, corner store initiatives and free produce giveaways at screening events, walking clubs, chair yoga hybrid. This has also been sustained the past 5 years. And we also engaged local high school students, 20 of them, for the magnet program, to go in and train seniors in their home to use a Chromebook, which we supplied through funding, and learn to log on to chair yoga. And so I mentioned that's been sustained. We're very excited about that. And another thing that we did was incorporate technology-based screenings into that with Washington State University, who, by the way, reached out to me when they were looking for a rural health expert in dementia prevention. They reached out to me. That's why you want to do that. Find your niche and concentrate on that. You can also think about other HRSA funding, to build service and practice and research all in one. So when you see this nurse-led mobile health unit by King et al., it's not a van that we take out. It's actually students who travel to the rural areas to offer education and screenings. And I just want to point out to you this little figure up here. This is the NBAC test from Dr. Cook's lab. She's really the one who designed the ability to assess for cognition level through the smartwatch, and I'm so thrilled to work with her. She has a ton of funding and hundreds of publications, and since we're all moving to technology, I encourage you to check that out. But what I want to explain about the ORCHID study is we had a initiative. It was consortium grant. So, a combination university and the state college, the local state college, to provide the idea of a circular, a circular model of care with education and screening by the students, followed up with the faith health educators who mentored them, and also the providers to be the referral source that we refer to. And we offered them generous stipends for being able to learn more about diagnosing and treating. So here's the ORCHID study. And the problem was, as providers, even with these very generous stipends, just said they did not have the time for training. And we worked with University of Washington. They have this hybrid where you join for 1 hour a week for 4 weeks, and then you follow up with your own time to, really get strong in diagnosis and treatment. And they just couldn't do it. So we pivoted to having adult gerontological nurse practitioners going to their homes, to the participant homes, to do in-depth cognitive assessments. They were already working at the Memory Wellness Center and had the skills to do this. And then they sent these very detailed reports with recommendations to the providers. And the providers really liked that because they could hand that to their patient and say, look, you were evaluated by the nurse. Look at, isn't this interesting? And this is what she found, and this is what she recommends. Because then they weren't the bad guys saying you have, cognitive decline and we need to do something about it. It just seemed to be a softer approach. And they have really, 9 out of the 10 of them that we surveyed, that of the providers really appreciated that. The problem is it was not sustainable. So we currently have one nurse practitioner who is residing there now. She's gone through the training with University of Washington, but she is not, she's known as a family nurse practitioner because she did a lot of other things before then. So the local providers aren't confident in sending referrals to her. So we have some other ideas to try to deal with this, which I'll go into in a minute. In the interim, we've been doing a R01 funded study. Dr. Williams and I are PIs on this, looking at 32 different variables. And we're trying to assess what the primary risk factors for Alzheimer's disease are, including burn from sugarcane and agricultural. I'm going to talk about that in a minute. I have a slide, but I want to point out this to you because this was very interesting. This top slide here this is a mini physical performance test, which you have the person bend down, pick up a penny, walk 50 feet, do a sit to stand 5 times, and balance with tandem and semi-tandem positions. And you could see, as expected, that people who are stronger physically have higher MoCA scores, right? Montreal Cognitive Assessment Score. But look here at the lives alone. We have so many people that live alone. That's in the blue. But look at their MoCA score. It's higher. So this points to the importance of social connections and social engagement, which we know are a big strength of this community. So here's some numbers. I just want to point out we've been fortunate to have a high percentage of males, and that's been with a lot of effort, which I'll show in a different slide. And many of them do not use email. And if you say I miss having people around me, no, over half of them, 68%, say no. So then, not to negate the fact that eventually that loneliness, if they are lonely, would be an issue. But so what does matter most to them? So this is the sugarcane on fire that I was pointing out to you. This is the smoke that's produced. It releases PM 2.5, which is like a small ash. If it falls in your hand, it looks like a pretty little snowflake. You touch it, it disintegrates. You inhale it into your nose and mouth, and goes in your lungs, your heart, and your brain. And it's a known risk factor for Alzheimer's disease because it crosses the blood-brain barrier. And so this is something that we're looking at, because instead of burning the stalks, which you do because they're so tough, even machinery has a hard time cutting through them, you could soften them with water. And we have this giant lake right there. So, there's some environmental injustice going on there, and we do get pushback from what we call big sugar about this. But what we're doing in that study is seeing if it's really an issue, because there's no good data on it, which is why we're funded. So you can see that we've had huge participation numbers in this. So it does matter to them. So I mentioned that we've been able to increase male enrollment. So recruiting at golf events, the men's fraternal organizations and retreats, asking women to bring the men with them when they come, or we'll go back, or we'll go to their home and get them. And also offering money for each person recruited. We haven't used it in this study, but I did it in a different one where we collected saliva samples for genotype. We gave them $20 for each person that they recruited that successfully completed the data collection. infection. So that's another something to think about. NIH allowed. And then these other things I've talked about, including trying to have telehealth ports where you have a clinic or office where you could get the person to them, and telehealth with a AGMP or neurologist. We're still struggling with how to get them into access to trials. Fortunately, we have something in the works to do blood biomarkers using dry blood spots on cards that's being reviewed this fall. So we're hopeful about that. So then in summary, the faith-based health educators felt that this was important to include this slide because it shows that resident involvement, or what we call resident-led research, is critical in rural communities. It strengthens the bonds between the different towns that we work with and the different leaders, and improves local decision making. We're working on transportation, so we have better public services listed there. That's something we're working on, while preserving their local culture. We have Hispanics, Haitian Creole, a lot of African Americans there. We have all these different cultures. So, respecting everyone's, trends and what they like to see when we're doing education and research has been really important. And then, anytime you're working with these, we're always involved politically with them as well. So increasing resilience to whatever's going on, especially in our current client, has been key. This is just a shorter summary of that. I do want to point out my colleague, Dr. Farron Epps' article. It's really terrific with synthesizing best practices to promote health equity for older adults through community engaged research. We have some more specific examples in there, some exemplars, plus boxes of tips. So I want to give a shout out to, again, Annie Eiffel, our Director of Health here at Glades, who's continues to really help us pull all this together. We're getting ready to do an Arts on the Muck. I can explain that later if you care. Our pastoral leader, Mr. Mans, and our directors of the Diabetes Coalition and American Heart, Debbie Walters and Cherie Wilson. And I know that Debbie and Jamel are on with us today. So big shout out. I'm so grateful for you guys. And Lake Okeechobee Rural Health Network. And a lot of this has been funded by our Regional Palm Health Foundation funder, as well as multiple grants. But anyway, so thank you very much. I appreciate you all hanging in there with the talk today. And I'm open for questions. Thank you, Dr. Levitt.
It was awesome. Thank you so much for your presentation. Any questions from the audience? Well,
Dr. Wiese, how did you get past that initial, when you said knocking on the door, I don't look like you, but I want to come in and work with your people? Like, was it just your consistency and showing up every week? What do you think turned the corner there?
Well, the minute you say you're a nurse, that really helps a lot. We all experience that in whatever we're doing. But I think, I feel like my strong suit is my ability to relate to people. And, I have a tremendous team. All of this research you've seen is because I have stronger people on my team to fill in the gaps. So I'm kind of the face of the efforts that we do out there. But I think, yeah, consistency, being there month after month, being there when you say you're going to be there. If they need you to do something extra, you do it. And attending to that, what matters most, bringing food while you're trying to do anything, and then moving to gift cards. I started with $5 gift cards. I did 300 people for my dissertation with $5 gift cards. So, I think just looking at what matters most, yeah.
Thank you.
Dr. Williams, I saw your hand earlier.
No, I was just applauding.
Oh, thank you. Thank you so much. That's great.
But I definitely agree that if you turned away the first time, then there's a second time and a third time. And pretty soon they get used to looking at you and say, well, maybe I'll take this person seriously.
Yeah, that's right.
When you are a nurse and you want to help.
That's right. And I think I think one of the things that helped was starting with the housing facilities. They need to have people offer education. They have to show their accrediting bodies that they're having people come in and do education. So I still do that to this day with them. You know, they need me to come give a talk once a semester, once a quarter. I do that. Dr. Sanders.
I just wanted to say that I had occasion to meet with an undergraduate nursing student who was working with Lisa on this project. And I asked her what was the most interesting thing that she had learned in doing this work. And she said that it was how important the churches are as cultural centers in these communities, and how different that is from her own experience, because she's always lived in an urban or a suburban place. So she had no idea. And so I think you've really captured something in the work that you're doing with that focus.
Well, thank you, Dr. Sanders. Yeah, it's really foundational to everything we do. We still meet every Wednesday at 1 o'clock, and we always start and stop with a prayer. And, you know, we tell people they can step out if they want, but also if we, well, what happened was we also decided to add a verse to it every week as part of the agenda offered by Pastor Mans. So we often have a discussion about that verse. So that's been really exciting, you know, what that means. And we also take prayer requests from the community. And you're right, that is really the key cornerstone. You're absolutely right. Thank you for pointing that out. And nice to hear my student learn something.
All right, any other questions? I just want to comment on how amazing it is that you grab all the resources and put it together and translate it into research. I mean, successful research. And it's not just the research itself, it's more of a community engagement that you did is wonderful. And the area of aging and brain health and gerontology, I think it kind of brings us the implication to nurses, researchers, and also for nursing students as well.
Thank you. Thank you, Dr. Mann. Yeah, I agree with you. It's definitely the community is the strength of that.
Yeah, any other questions? It was really nice to hear your presentation, and I want to share that we have an annual conference coming up. So if you haven't registered, please come in for register for the October 21st to 23 annual conference from the NHCGNE. And if you have any questions to Dr. Wiese or me, or for the NHCGNE conference, anything, please email us for this. And please fill out the survey if you can. Otherwise, I will end our fireside chat for today. And so sorry for the technical issues. And I'm sure we will work on it next time not to have these occasionally events. So sorry for that. And then Dr. Wiese, thank you so much. And everyone who attended, thank you so much for your evening time. And I'll see you in next month in the annual conference.
Thank you. And I just want to put a plug in for the annual conference. It is virtual, so you can, and the talks are recorded, and they're a wonderful way to get CEs. So there's so much great stuff going on with AI and nursing. I really, really encourage you guys to just, even if you can't, be sitting there for 2 straight days to attend it, still register, get access, and take advantage. It's fabulous and it's affordable. So just a shout out there. And then, yes, I'm happy to share the slides, of course. I will send them to you, Dr. Moon. Thank you.
Thank you. Awesome. Thank you. Bye, everyone.
Bye.